this portion of the summit, we're shifting our attention to how providers innovated healthcare options during the pandemic, how patients were affected, especially older adults, and how the changes we've seen so far will likely impact the future of telehealth. With us for this telehealth roundtable portion of the summit, we have Chelsea Chopransky, who is Assistant Director of Digital Health for Munson Healthcare, Scott Shelton, who is the Assistant Vice President of Operations for Paragon Rehab, Laura Kilfoyle, who is the Telemedicine Policy Specialist of the Medicaid Policy Division for the Michigan Department of Health and Human Services, and last but not least, Dr. Tom Camber, who is the founder and executive director of Older Adults Technology Services, also dubbed OATS for short. Thank you, everybody, for joining us today. We have some big shoes to fill after our first panel. Thank you. Feel free to come off mute, and we'll just start this discussion. I'd like to encourage our audience to send us any questions for the panelists that you may have. I see already that there are some Q&A, so we will get to those. But first, I want to give our panelists an opportunity to tell you a little bit about what they do, their approach to telehealth, that type of thing, and why you'll understand, I think, why we chose these four to take part in this once we hear from each of them. Chelsea and Scott, I'd really like to start with you both, since you're both leaders in respective healthcare agencies. Chelsea, ladies first, can you share how your group approached the sudden onset of the pandemic? Suddenly there was this huge need for telehealth. Can you share a little bit about how your organization approached this?
Yes, absolutely. So first, thanks to Connected Nation for hosting this forum. It's a very important topic right now, and happy to be here. Prior to COVID-19, Munson Healthcare is a system. We're a 9-hospital system that spanned 30 counties in lower northern Michigan. And we recognized prior to COVID that telehealth would definitely be an important part of healthcare industry going forward, and would continue to play an increasing role in patient care. And so actually my role was new. I joined Munson last March, and part of that was recognizing they needed a leader to manage that work. And when I started, we were working on a multi-year telehealth plan to cover it in all of our hospitals and our practices. So we recognized it was a need, but definitely not the speed with which we would be implementing. So when COVID did hit, we very quickly had to reevaluate our priorities and greatly increase our response to that. So we didn't at the time have really any virtual visits in our practices, and that was the first immediate need that we had. Michigan was really in the middle of a shutdown where it was very difficult to provide care, and so we had to make sure that we had some type of platform beyond telephone visits to be able to offer video visits to patients, so they could remain in their home, and our providers could either come into an empty office or work from their homes and still continue to provide care to their patients. So that's kind of where we started last year. And since then, it's been a year-long journey trying to optimize and just make that better for our patients and for our providers.
So at the time, was Munson delving into telehealth at all, or were they just starting to go down that path?
We had done some of it on the hospital side using, physician-to-physician consults within the hospital, but we really had not done anything on in the provider practices. So that was a brand new venture for us that we got set up in a few weeks very quickly. So since then, as I mentioned, there's been a lot of, training providers, making sure the technology is working well. A lot of incremental changes have happened since that initial implementation.
And Scott, I want to bring you in here because you're really on the rehab side of things with Paragon. Tell us a little bit about how your company approached it. It was really very new to Paragon, correct?
Correct, yes. Again, I want to thank you, Jessica, and Connected for inviting me today. Very excited to talk about this. And you're correct. Yeah, we did have to pretty much dive right in. So last year, Medicare, basically, because of the COVID-19, were able to allow for physical, occupational, and speech therapy to provide services via telehealth. And because of that, obviously, we wanted to make sure that we could reach our residents and make sure that our residents were being up, as well as providing caregiver education to those for those residents, for the caregivers there. So basically, we did have to, like I said, dive right in and come up with a protocol and system, put some things in place in order to deliver these services, and really, be able to provide the education to our teams as well as our residents, because mainly our population that we provide services to are the elderly population. So we really had to provide some education surrounding that for them, really looking at the platform that we were choosing to use for them, so that way that they were able to successfully use the platform to have telehealth visits completed.
I think a lot of people might consider rehab or physical therapy as something you can't necessarily do through telehealth, but it is something that you can approach depending on the care. Is that correct?
That's correct. So depending on the resident's plan of care, will really depend on, who is appropriate for telehealth. There is so much regarding education and or, being able to instruct a patient to perform certain tasks that is reflective of their plan of care that they can do, or maybe even do in conjunction with the caregiver. So we're able to provide some of those services. Obviously, there are some services that we're not able to provide via telehealth that has to be appropriate for the resident.
And have you found the response to be pretty good with even, I know you probably deal with a lot more older patients in general, I'm generalizing, of course, but were they able to adapt to it, do you feel?
Some were, and some really, had struggled a bit, but I think that was one of the key pieces about choosing the platform that we use to make sure that it was user-friendly. What we try to do is practice with that individual when they're in one of our facilities before they were to discharge home. And then, so that way, at least they had the ability to practice and use the telehealth system, either through their phone or through their tablet or computer. And then at least when they get home, they know what to expect. So in the system that we use, it basically just sends a link directly to that resident. And then that person can just click on that link, and then it immediately connects to a HIPAA protected FaceTime, if you will.
Laura, I would like to shift to you for a moment now. Scott said something that was really telling, and something I've heard from a lot of healthcare providers, that lifting of regulations really helped. Just a reminder for our audience, because I know I went through everybody's titles pretty quickly. You're the telemedicine policy specialist for the Medicaid Policy Division of the Michigan Department of Health and Human Services. So on a state level, you provide a lot of guidance and details on telemedicine policy, which became critical last year. So share a little bit about how what your role is when it comes to those regulations and how your agency approaches this.
Yeah, so thanks everybody for having me. Appreciate the opportunity to have this discussion. This is pivotal and just so wonderful to hear all the great thoughts from folks. But so I sit within the Medicaid Policy Division, and my role is really to assess and determine what our telemedicine policy is going to be. States have pretty wide discretion to determine their own policy. There are obviously factors that we consider as far as Medicare policy and all sorts of other factors that we take into consideration, but we do have discretion to do this. Now, we were pretty fortunate. We had actually started looking at our telemedicine policy and doing some preliminary studies on what we wanted to change moving forward. But our approach to telemedicine, especially as the pandemic really began ramping up, was really about increasing access. We knew that the prevailing word was stay at home, stop the spread, keep folks from engaging with anyone outside of their home. So we knew we were going to have to take a very aggressive approach. Our policy had been pretty stringent for many years. And so we knew we were going to need to open up, reduce barriers, and allow providers and beneficiaries the option of participating in telemedicine visits. So we took an aggressive approach, and we said we are going to remove barriers. We're going to help people within the relationship with their provider to have those visits. And we opened up home as an originating site. We opened up, we released barriers for providers to be located where they were during visits. And we really just looked aggressively. We also, just keeping in mind, obviously our telemedicine policy really focuses on the ideal being an audio-visual connection with a beneficiary. And that's really ideal. We want to ensure, that beneficiaries have that ability to see their provider, the provider can see them. But we knew during the pandemic, as we've all been talking about, the digital divide is an issue. And so one of the things we did as well is we said, not only are we going to, release restrictions on audio-visual, but we're also going to allow phone-only visits for telemedicine as well. So again, understanding that we don't live in a perfectly equitable society where folks have access to broadband, why we're all here. We also wanted to, ensure that that was something that was open as well. And then as the pandemic persists, we really started to open up additional services. So like Scott was mentioning, we opened up physical therapy, occupational therapy, speech therapy, dentistry services, audiology services, again, adapting to this pandemic, which was really persisting. So, so overall, our approach was really increase access and be aggressive.
Well, help the average person explain what it takes to make that kind of huge pivot in this framework.
Yeah, so as I was mentioning, we were actually studying a lot of current telemedicine policy and looking at what we were going to do with our policy even before the pandemic had started. So I'd like to say we had a crystal ball. We didn't. We knew that the industry was changing, and we knew that there were things that we would have to bring our policy up to date. So we had been looking at what other states were doing. We had been looking at what the current research is looking like. We had been looking at all sorts of different things, and also our legislature had been getting involved as well, and they wanted to see some opening up of our policy. So probably the single biggest change to our policy at the beginning of the pandemic was really opening up the ability for beneficiaries to participate in a visit from home. So again, our policy before had been that beneficiaries had to go to a certain location to participate in the visit. We said, no, let's say beneficiaries can be at home or another site deemed appropriate by their provider. So that was probably the single biggest change that we made right off the bat. And again, we had no idea, that we'd be entering into a global pandemic where folks would be required to be at home. But we're so thankful that we were able to do that right at the beginning.
So what have you heard from providers? I mean, Chelsea and Scott could maybe speak to that some as well, but are you keeping some of these changes at least for the time being? What's the plan? Are you still working on that? Are you polling other agencies across the country? What's your approach moving forward?
Yeah, so I think it's a combination of all of the above. So the first question I'll answer is we are keeping our temporary COVID-19 response telemedicine policies in place until at least the end of the federal public health emergency. So obviously the Biden administration has issued the federal public health emergency until at least the end of December of 2021. So we are keeping those policies in place until at least that point. We figured that was a good way to kind of put it out there and let providers know that we understand that these are pretty significant changes. We understand that changing back to a post-pandemic world and changing your policy would be significant. So we wanted to give that space to be able to do that. Now, understanding, of course, we're in an ever-evolving situation with the public health emergency, so that could change, but at least until the end of 2021. And what we're hearing from providers, and we have providers on here who could speak to this, I'm sure, even better than I can, but what we're hearing is just providers being very thankful for releasing those barriers and relaxing and allowing these flexibilities. So, I think they're thankful from the standpoint of being able to continue to serve their beneficiaries, our Medicaid beneficiaries. But also it's the piece of allowing them to do it in a safe environment where they can ensure that they also remain safe. We obviously want our providers to remain safe and not having unneeded exposure to COVID-19 and to bring that home. So that's a lot of what we're hearing. I think, I was really impressed with the way that our providers ramped up their telemedicine practice, like immediately. Amazing, all of you. That's a credit to all of you on this panel. Just amazing. We saw our numbers just skyrocket, almost unbelievably. And so I think we've heard just a lot of thank you for doing that. Thank you for allowing us to have the flexibility to do that. Now, as we look forward to a hopefully post-pandemic world, I'm confident we'll get there at some point. We're looking to see what makes sense moving forward post-pandemic. We obviously, as the other panel so eloquently put, and as I've heard so many times, the genie's out of the bottle, the toothpaste is out of the tube. Telemedicine is never going to look the same as it did in January of 2020. But we know that there's some sweet spot there. And so we're trying to find that. We're talking with providers. We're looking at data. We're looking at studies. You're looking at other states. We're in conversation with many other states and what they're deciding to do. So it's a whole of view, trying to listen to as many folks and as many data points and as many studies and things that we can to try and develop that sweet spot.
Well, I'd really like to get back to Scott and Chelsea in a moment and talk about what you hope to see with telehealth moving forward. But first, I'd like to welcome Dr. Camber as well. Thank you for being patient for a moment.
No
I
problem.
first learned about your organization, Older Adults Technology Services, when your organization released a study that was pretty sobering on how the lack of the connectivity affected older Americans during this time. I'm just going to quote one stat from it. Over 80% of COVID deaths in the US have been older Americans, and research estimates about 40% of them were unable to access critical online resources that could have helped them. What does that say about the need for telehealth access and how we need to approach older adults in America?
Well, Jessica, thanks for inviting me on the panel. And I'm the only New Yorker on the panel, so please don't hold that against me. But I'll try to keep up with you guys. But this study, what's really startling here is that as a country, we've sort of accepted a kind of a private crisis amongst older people that relates to their technology and social isolation. And when the COVID crisis started, I actually went back to my bookshelf and reread this book by, I think his name is Eric Kleinenberg, and it's called Heat Wave. And it focuses, many people who went to public health school have read this book. It focuses on the 1995 Chicago heat wave, where close to 700 people died, and most of them were older adults. And what we learned from that crisis was that social isolation is a killer for older adults, not just the isolation for the health factors, but when there's a crisis, it puts older people at a magnified risk of all of the negative consequences that we're facing with these situations. And so we started raising a lot of an alarm here in New York City, and then ultimately around the country and our other locations, about the need to solve not just the isolation piece of the equation, but really the technology infrastructure piece of that as well. And New York City got out a little bit in front and created a project to bring older people online in the public housing department here, and distributed 10,000 tablets to people with connectivity from T-Mobile. And we started working with Humana, the Humana Foundation, which is based in Louisville, Kentucky, but has a national footprint. And they said, what do we really need to focus on? We said, first of all, nobody's exactly sure how many seniors are offline. Like, we don't actually know the answer to that question. There's been studies by Pew and others, but if you dig into the data, it's not really very granular, and there's some issues with how we calculated it. So we asked if they would support a project called Aging Connected, which starts with a snapshot of who all these folks are, and then is meant to be a launching pad for trying to overcome the digital gap for older adults. And so we brought together a couple of really prominent researchers, and just the real snapshot, kind of high perspective points of view. One is, it turns out that about 42% of people over the age of 65 in the United States lack broadband at home. They don't have wireline broadband access at home. Now, some of them are getting online through cell phones, and some of them are getting online through God knows what DSL, or stealing their Wi-Fi from their neighbors. We all know about that. But most people are struggling. And in fact, what's happening is, not only and that, by the way, because there's so many older adults in the United States, that translates into 21.8 million people. So just take a moment and realize how flabbergasting that is. The minute that COVID started and people had to mask up and stay home, the first thing people started doing is buying toilet paper online and communicating with their friends and family via Zoom, and handling all of their, digital transactions with their banks and things. And just think about how we kind of, tied one arm behind the back of the older adult community in the United States, and made people have to kind of confront the crisis with all of the negative consequences of being older and the risk factors, but then having this burden of not being connected. And so we started looking at those numbers. And the other big picture pieces are, it turns out that a lot of social equity factors overlay this disconnected population. So it's not just randomly distributed amongst people over 65. It turns out, no huge surprise for people to pay attention to these things, but if you're African American or you're Latino, you're 2 to 3 times more likely to not be online as an older adult. If you live alone and you're a single older adult, more than twice as likely to be offline. If you live in a rural area, 1.6 times more likely to be offline. If you're low income, 10 times more likely to be offline. So these these equity factors are magnifying and compounding the digital disconnection of older people. And we're looking to come up with plans to bring people online. I can talk about that later, but it's only a piece of the telemedicine puzzle, but that connectivity for older people has to be addressed. And Oates has a lot of trainings and programs that we work on to try to solve that. But boy, we really need people's help on this one.
And really, if you were listening at the first part of the summit with the Lieutenant Governor Gilchrist talking, he addressed the issue of equity among communities of color. And the study also found a lot of disparity for communities of color and minorities, correct? So it really, knowing those targets, knowing the challenges that older Americans face, does that make us better equipped to start to address this in your point of view?
I think so. I mean, I think having a grip on reality is usually the first step towards solving problems. And, we just didn't know. Everybody knows, that older people are having some struggles with technology, but I heard so many people say things like, yeah, but they're on smartphones, so it's not going to be that big a factor. And of course, now that we've lived through a pandemic, people realize what a big deal this is. And also, when you look at the country is going through a very needed and really important period of addressing, racial and other inequities that are really, really have been festering for decades and centuries. And so these factors, but by being clear about where the problem is, we can start addressing it. And so just two quick examples. One is, until the recently passed emergency broadband benefit, which is, I can talk about, it's a new subsidy that the federal government is initiating to help people get online. Until that, there was no federal subsidy for broadband access that was like widespread that people could take advantage of. And so figuring out how to get people to that subsidy and support older people who are not online in becoming early adopters of using those resources is a very high priority. And so knowing that we have those pockets of challenges is really important, and activating groups that are active in the civil rights community, or groups that, there's 42 million Spanish speakers in the United States. And one of the most critical groups to reach with older adults that are offline are Hispanics. And so how can we invest in partnerships with communities there? And then the other part of it is looking at geographies. The internet access program, Comcast has this Internet Essentials program, which is, very well regarded and known. But that only operates in 40 states. And about 50% of seniors who live in those states can take advantage of it. But for the most part, they're not, and they don't know about it. And what we found is that this gap between young and old in terms of broadband access is very locational by geography. So I looked up Detroit recently, by the way. We looked at metropolitan areas. Detroit comes in dead last of the top 27 metropolitan areas in terms of home broad wireline access for younger and older adults in the categories that we looked at. But the gap between young and old has you in 10th place, which means that to the extent that we're trying to look at places to zero in on, that, the gap there, I think it's 11% right now between young and old in Detroit, but there's certain other areas where you have these huge gaps where older people are really offline and younger people are more online, like Boston is at 30%. So there are ways for us to target our efforts and try to close the gap where we know it's most acute. And those data points can really help us figure out where to apply these scarce resources.
I'd like to pose my next question to Chelsea and Scott regarding how providers' role in helping older populations, moving telehealth forward. What do you see as that? Maybe Chelsea, you can begin, and then Scott, you could take it. What do you see are the role of providers in helping to bridge that gap, as in healthcare providers, not internet service providers?
Sure. Yeah, telehealth is new, especially in the patient's home, to really everyone because of the reimbursement restrictions that existed beforehand. So one of the big things we've tried to equip both our providers and, most importantly, our scheduling staff, those who are talking on the phones with patients, is more information on what is a video visit, what makes sense for a video visit, what doesn't, that education and almost reassurance for those who might be new to it. The information that our providers are looking at their schedules, they understand what works well with video visits and definitely what does not. And if we're recommending for a patient to be seen via video, it's because it's clinically appropriate. They will be able to get that same level of care. So I think a lot of it, and I know the prior panel talked about it too, is education and reassurance for the patients. Another thing we're looking at, and I've seen some other health systems do, is data, understanding also the clinical appropriateness of quality across video and in-person visits, as well as I've seen some health systems looking at where they're more likely to have phone visits versus video visits. That can be a good indicator of patients might not have the right technology or broadband access. And how can we better support those areas? So I think it's the front end education, and then back end, how can we use data to better inform that education or add more resources to specific areas.
And really, just to echo that, I mean, education is the biggest, key, is really key to this, making sure that not only the patients that are going to receive the telehealth visit, but also those that are delivering it, they both, need to receive that education up front. Because if they do receive that education and have a good expectation of what's going to take place, why is it taking place this way? Really knowing what to expect from that visit is going to help out both. So, for us in our organization, what we did is really sort of create some examples for using our clinical team as a great support to really make sure, as Chelsea mentioned, to make sure that it's clinically appropriate. It may not be clinically appropriate for everyone, or there may be a portion of that person's plan of care where it is clinically appropriate to provide a service, via telehealth. So really providing some examples and giving that education to our teams to make sure that they understand, why they are providing this, because this was totally new for them too, right? So they're in the middle of this pandemic along with everyone else, along with their patients. They're trying to figure out, how can I still provide great care, but I'm going to provide it via telehealth? What does that look like? And so it really just, the education was the biggest piece for us to really, make sure to get in front of that. And as you said, then start collecting some data, getting feedback from patients as well as our therapy teams to really know, what do we need to tweak? What do we need to change moving forward to make sure that everybody has a good understanding and feels good about the service that they are receiving. Oh, Jessica, you're on mute.
Thanks, Scott. I was told to mute when I wasn't talking. Does it surprise you, some of the data that Dr. Camber was mentioning, or is that seem like some of what you've experienced in the field, that there's a lack of technology that these seniors or older Americans need access to?
Yeah, for me, I mean, it's always shocking when you hear the real numbers, for sure. And I think for us, what we were really looking at is how to get, in front of the residents that we had specifically in the states that we were providing services for. But looking beyond that and making sure, just because someone doesn't have the connectivity in order for us to provide the service, we didn't really have anything in place to kind of help them through that after the fact. So now our social services department and those, individuals are really kind of tapping into to try to maybe give them resources or connect them with the right people within their community so they can have that connectivity in order to receive those services. So
really the different problems that we're seeing here that we're discussing is, the healthcare provider side of things, the regulations side of things, the research side of things, how those all come together. Laura, I do have a question from our audience, concerned that things won't be reinstated or that there won't be post-pandemic telemedicine available, but that's not necessarily the case, right? You're still exploring the restrictions and requirements that will be around that?
Yeah, so in reading that question, so it sounds like what this questioner is asking about is the specific CMS exercise of their enforcement discretion of the HIPAA rule. And unfortunately, we have no discretion over HIPAA. HIPAA is a federal requirement and HIPAA is a federal law. So what they're speaking about is HIPAA the Office of Civil Rights chose to allow enforcement discretion during the pandemic for platforms that may not be specifically HIPAA compliant. And so they opened that up because basically, as we've been discussing, all these providers had to quickly stand up their platforms. So they said, we're going to exercise enforcement discretion. If you are putting a platform in place and you have, you're reasonably trying to, ensure that beneficiaries' privacy is secured, basically you're not going to get in trouble. And now I am not an attorney, but that's the basic understanding there. We don't have any purview over that. So we require HIPAA regulations to be in place. So we defer to the federal government for that. Now, where we have discretion is the types of telemedicine that we allow. So what types of visits do we allow? What types of modalities? What specific CPT codes? What types of providers and things like that? And that's where we are, we opened up a lot of that during the pandemic. And that's where we are looking at what our post-pandemic policy is going to be, based on our experience during the pandemic and all these other factors that we're kind of exploring as we speak here. So we don't have any purview over this. They might choose to exercise their enforcement discretion post-pandemic. We don't know. But we are in all the areas that we can exercise our control and our policy discretion. We are looking at all those areas as we speak. Yep.
So just for understanding's sake, how do you interact with providers? As in, how are you taking in the new research? Because obviously we've been through something that we've never been through with the pandemic. No one knows when it's going to come to an end, really. And so there's all these unanswered questions. How do you make these policy decisions in that environment? Are you in close contact with providers? Are you really paying attention to the data? How is that approached?
Yeah, it's really all of the above. So usually in policy development, it involves contact with providers and getting feedback. It involves looking at the data. We're constantly pulling numbers and seeking our claims and encounter data and what that looks like. It includes different groups that we're a part of with other state Medicaid programs. It includes connections with federal policy. It includes any sort of listservs and research that you can possibly imagine, which normally during a normal time is a lot. During a pandemic, when telemedicine is on everyone's mind, it is a really lot. So we're absorbing all of that. We're taking that in. We're always open to feedback and discussions with providers. When we put out policy, obviously we offer avenues to give public comment on that policy. But we're really absorbing, sometimes I call myself the big sponge because I'm trying to absorb all that information that's coming in. And, one thing about telemedicine policy is, it cuts across so many different areas of the department. So we're talking, different, behavioral health, physical health. It crosses over into therapies. There's so many different areas that it cuts across through even policy. But then when you look at our diversity and equity and inclusion work, it cuts across that. So we are, we have a lot of people who are watching this, who are talking about it, who are considering options, who are bringing their own experience, bringing the experience of their family, and then just all the ways that we can absorb that information and moving forward. It sometimes feels daunting during this time because there is so much information and so many things happening in this space. We always encourage folks to reach out and provide feedback. And like I said, our formal mechanisms are public comment and our policies and things like that. But any of those informal ways that we can get data, we're all ears at this point, and we're really listening and learning with everybody else.
Dr. Camber, Laura mentioned the different ways that telehealth are used, the different, from one-on-one doctor care to, rehab to all these different things, including mental health. The reason I bring that up with you is because digital isolation was a big part of the study you did for older Americans, and that telehealth really can play a role in that. Can you share more about that? There's been a lot of research out about the benefits of telehealth when it comes to mental health. People are more willing to talk, that type of thing. But it goes even further for seniors, right? Just even the fact that they're so isolated. Can you share a little more about that and discuss why that's important?
Sure. And by the way, Laura, anytime you want to come run our programs here in New York, you're welcome, because that's exactly the right kind of the sponge approach to learning through this stuff is really important. And I think that we're really gaining a lot of insight each year as we iterate a little bit and come up with new solutions. What we've been finding, and again, I'm not an expert on the health side, as a practitioner or academic, but we certainly, we had 212,000 participants on our programs in the last year since COVID started. So we've had a lot of activity on our sites. We run all our programs through a website called seniorplanet.org. And in many cases, we'll run sessions which can range from basic information about how to use the internet, but also getting into health and even wellness resources. And I can tell you, by the way, that from just a kind of random user standpoint, the most popular programs at Oats and Senior Planet lately have been around wellness. And the most anecdotally, we have like 500 or 600 people in every one of our Zoom sessions now, these morning stretches, which we used to do in New York with like 14 people in the room. And now we'll have 600, and people come early, they stay late. They're creating these kind of mini communities of activation and making friends and contacts. And when they're speaking, I get on the sessions periodically and just kind of ask what's going on and have people share with us. And these mental health issues come up in a kind of ancillary fashion all the time. People say, this has been a lifeline for me. I've been feeling so lonely. And in many cases, their participation in these group activities is really helping them create the socialization that allows them to feel more optimistic and more engaged. Many people, of course, have pointed out that mental health challenges, they carry this stigma. And so there's something about getting in the car or on the subway, going to an office and having to physically be there in the waiting room with other people, and you're not sure, if they know who you are. There's all of this anxiety around mental health treatment. And so in some cases for people, the telemedicine option is definitely better. They prefer it. It's less stressful. There were years ago, we've worked with groups that have been doing telemental health programming, and we've been helping drive people to some of those initiatives. And so there's definitely a there, and it does help people. And I will say, in terms of outcomes, people participating are having significant benefits in terms of social engagement and some of the benefits psychologically of being on this. We test, for example, sleeping patterns as one of our survey questions, and people sleep better after they're more connected to each other through digital programming. So we're getting results from that. Then the other thing just to throw out there that I think is really critical is that there's a gendered format to this. For older people. And I'm not sure so much about the younger populations, but definitely older men and older women have different patterns of seeking help. In many cases, women tend to participate more actively in service programs and support programs, and men need special kinds of outreach and environments where they feel more comfortable. Some of these telemedicine approaches and telehealth options may be better for men than for women. It's not proven yet, but I would flag that as an area to look at.
That is very interesting about the gender differences that there could be, but I can understand that, especially with older populations. They may have some, you got to be a tough guy kind of mentality sometimes. For digital isolation, I also would like Scott and Chelsea to weigh in on this one, because I've heard from a lot of doctors that they can see what the home life's like. Is that what you're finding, Tom, about being able to have that access, that it also means that we can be a part of their lives, that instead of being very dismissive, the older population, which sometimes Americans can do?
I think so. I mean, I think it forces us to confront the ageism that is so prevalent in the US. And I'm sure many people on this call are really, very familiar with this, but the last few years, there's been a real awareness of the issues around ageism, the bias and the negativity that American culture carries around aging. And so we often, we tend to push people into the shadows a little bit. And I can tell you one of the most common things that I hear, we run this center here in New York City called Senior Planet in Manhattan. And I hang out there a lot. And just before the pandemic started, a woman pulled me aside at the center. She said, "I need to talk to you for a second." And she said, "What's special about my participation in Senior Planet," she said, "is I feel invisible as an older person." She said, "When I walk down the street, she'll go to a store and people will walk in behind her and they'll take the people behind her in line before her just randomly." And there are these, kind of microaggressions against older people, and they experience that. And finding ways where where older people can be visible and where we can feel like we're able to see each other and respect each other, not just as a character, but as an actual living human being in a context matters. So for some people, the telemedicine environment, being able to get into the home is beneficial and helpful for them. But we also have to remember that older adults are not in any case monolithic. It's not, a simple category of like, oh, we're all similar because we're over 60. And there's going to be extroverts and introverts. There are going to be people that are very comfortable with their physical and visual manifestations, and others who are really uncomfortable and have to really get nurtured along with it, or maybe just are always going to be off camera, but they still want to participate on the audio side. So we have to create a kind of big tent around it. One that I think it was Chelsea that mentioned earlier, maybe it's Laura, that some programs you have to do on the phone, right? Like Zoom's not the only way. Like technology can be a telephone call. It can be anything that really helps us reach people. So creating those multiple kind of no wrong doors into the system is really critical. And I think that, these systems are getting better. As long as we don't let the technology become a fetish that somehow is justifying not doing the face-to-face in the future, right? We need to add into the system so that it's better and more resilient 5 years from now, rather than, we took all the digital stuff that was good and then dumped all the face-to-face stuff, which was expensive. And we don't want to do it that way. We want to make sure that we're more inclusive and building a better system for everybody.
And just to speak on that as well, sort of like a role reversal, Jessica, because you had mentioned about, being able to see into their home and be a part of that environment. Also for us, because the majority of our business is in skilled nursing facilities. So really allowing, we didn't always do telehealth where it was the resident who is receiving the service. We may be providing the service there hands-on with the resident in one of our locations, but we would telehealth in maybe their loved one. So that really provided a time that they would, be able to, the loved one could be helping us to encourage the patient, to go through whatever therapy plan of care that we've created for them. But then also it allowed them to really have that socialization with their loved one, which really helped that person, because all of a sudden there was no visitations that were allowed. And they were really locked down, and that really, it affects everyone differently, but especially if you're already in a situation to where you feel secluded and you feel like you're already, kind of there. And then now this added layer from the pandemic on top of it, we also use telehealth in that way as well, even if it was a phone call, during the therapy session to their loved one. And that was very beneficial for the patients.
Yeah, I just reiterate, we've definitely heard from our providers as well, the benefit, our primary care providers or those providing care to those with chronic diseases, being able to see in their home, see what type of support system and people they have at home with them, and how they're living, and how that contributes to the disease that we're treating medically has been a big advantage for our providers. We also have patients, especially when they're on several medications, don't always fully understand what types of medications they're taking. It can be really confusing. And we've had instances where the patient can go to their medicine cabinet and bring over their medications and explain, here's what I'm taking when, as opposed to saying the green pill, on Tuesdays. So that's been a huge advantage for our providers and our patients. We also, and just in general, this is something we expected with virtual visits, but in Northern Michigan, our winters can be really difficult. And so being able to, if we do have a snowstorm, instead of canceling a ton of patients or risking either our patients, or we have providers who travel long distances, being able to complete those virtually, we've seen some big benefits with saving time and safety as well in the winters.
Yeah, that is one thing about also rural areas where some hospitals are closed, being able to have access, don't you think, with that?
Yeah, absolutely. Yeah, we have one endocrinologist in our system, and so she sees patients from all over Northern Michigan. And so she's been doing majority, 70 to 80% of her patients. Anyone who can upload their information to the cloud, she's able to see via video. So she's saved a lot of her patients she has regular check-ins with, a lot of time traveling back and forth.
On that note, we have two questions from Jim. Both are kind of similar, so I'm just going to pose them as a two-part question to you and Scott. I think that these are meant for. Because telehealth could be potentially cheaper for a lot of health systems, he's asking if that means that clinicians or doctors will try to force that direction. And also, what about securing these systems like the Fitbit or your ISP, that kind of thing? So two-part question. One, our doctors are still looking at, what's best and not just this is cheaper. And how do you secure these things?
Yeah, absolutely. I think reimbursement will play a big role in that. Right now, we're reimbursed at the same level for video and in-person visits. Phone, it depends by payer. And so that does allow our providers, they don't really have an incentive either way. They're able to make the decision based on what's clinically appropriate. I do know there's potentially interest long-term in moving video visits to be reimbursed at a lesser rate. And I think actually the opposite might happen, is providers might be more willing to do in-person visits because they might get paid a little bit higher. So that's something we're definitely watching. I think that'll be an important part of the reimbursement conversation, is how do we make sure that doesn't impact how we are providing care. I think also patient expectations will continue to evolve. I think we'll get to the point where if the patient doesn't have to drive in, they're not going to want to do that. They'll find a provider that will see them virtually. You know, it's the same with online shopping. A lot of other industries have gone through this, and I think healthcare is just starting, where patients are just going to start asking, and they're not going to see a provider if they're not offering virtual visits.
And Scott, how do you think Paragon is going to approach those two things?
I agree too. I mean, a lot of it is really going to depend on, just from a business standpoint, a lot of that's going to really depend on the reimbursement and what that looks like. Obviously, you know, we're an organization who our core values is really to provide the, you know, clinically appropriate and the best care for those residents. So if that is telehealth or if that's in person, we're always going to want to choose what is the best for that specific resident. You know, and really cater that delivery of care for that individual. But really a lot of it's going to be on reimbursement. We like to have this in our pocket to be able to utilize. This isn't, you know, our first method of delivery of services that we're going to choose typically. But it is nice to be able to have that, so then you can still reach those individuals and provide those services, you know, even during a time that that we're currently in.
Go ahead, I'm sorry.
If I could jump in on that. Yeah, this is Laura from a policy perspective. I really appreciate that question, because as a policy writer, that's one of the things that we worry about, right? We worry about, telemedicine being provided because the provider actually sees that as the path of least resistance, so to speak. So we actually do worry about this. This is something that we, as people are, I love telemedicine services, but I will always say to my dying day, it has to be the right beneficiary at the right time with the right situation. So not every visit is going to be, it's going to be great via telemedicine visit. Not every beneficiary is going to want the visit. And, providers, we have great providers on here who are obviously advocates for telemedicine, but there are a lot of providers who say, I don't think so. I actually have a personal physician who says, I do not want to do a telemedicine visit. I want to see you. I want to put hands on you. I want to listen to your heart. And I said, Doc, this is what I do for a living. Like, come on. And he's like, no, I really think it's important to be with you. So there's a lot of things that kind of have to line up to ensure that a telemedicine visit happens the way it's supposed to. And we really want to make sure from a policy perspective that we don't kind of hit both, that we don't allow either side of that, either all in person or all telemedicine. We want to find that middle spot where within the provider beneficiary relationship and within the situation, it's the best visit possible. And that's challenging. I mean, those are things that, this is not, I don't see this as an easy route for providers. There's a lot of things that need to come in place to make these visits happen appropriately. But this, a lot of our conversations do revolve around that, ensuring that we keep those providers on the edges, from either 100% telemedicine or 100% in person, because there are very few people who I think would be 100% telemedicine. I can't imagine that there wouldn't be a time to go in and talk to your physician face to face. However, I think there's a lot of visits that could be done. And a lot of the research and the questions we're asking too is just finding those most appropriate types of visits, whether that's, we do it by CPT code. We say, okay, these are the ones that can be performed via telemedicine within these specialties. But there's flexibility there too. We allow general office visits. And again, lots of people can do those, effectively. Other people can't. I'm also seeing that there's now there's some medical schools that are actually starting to train physicians to do these types of visits, but the vast majority of physicians who are practicing right now didn't go to medical school and learn how to do this. So there's just so many things that we're trying to make sure that we're hitting. And again, within policy, just trying to make sure we're hitting that sweet spot and getting that appropriate visit at the right time with the right provider. But it's a challenge. It's a challenge for sure.
Jessica, can I just add 2 cents to what Laura said? We did a project here in New York, in Brooklyn, a bunch of years ago, kind of almost in the early telemedicine days. And we were working with the geriatrics department at a local hospital. And they were interested in finding out whether people in their 80s primarily would be able to participate in electronic medical record usage, which involved a lot of early stage kind of emailing back and forth and doing record sharing online. And we ended up getting computers donated from Verizon. And we didn't know if people would even do this. I mean, it was early days, and many of the people were really like older, into their 90s. We started out the program, and first of all, we learned three things. One was that the older adults loved the technology and they thrived. They were really into it. They were having to enter their formularies into the computer. And we had people like hunting and pecking at the keyboards. They were really, really dedicated, and they loved doing it. When it was set up for them to succeed. We had trainers working with them one-on-one, and they were succeeding. Two is that the geriatrician played a huge role in whether or not the older adult participant would actually engage. So when we did our first round, we were trying to sign people up. In the first round, we had a little bit of interest, and then suddenly the phone line was flooded, and we signed people up in like a week. And we called them up and said, "Why were you all applying?" And they said, "Oh, because Barbara told us to." And Barbara was a geriatrician, and they all loved Barbara. So when Barbara said, "Technology is not your enemy, technology is your friend," the discussion was over. Like the whole orientation changed for people. And the doctor, the medical provider really made a huge difference. And the last thing is really what Laura was getting at. There was the head geriatrician and her two colleagues that we worked with, and two of them were tech positive, and the third one was not and didn't like using the technology. And we came away from the study after a year of working with them and realized, wow, the two tech positive providers were super, super engaged, and they really loved using it, and they really worked with it. And the other one didn't. And that didn't mean that they were providing higher or lower levels of care. It was just their orientation toward the care. And it was really noticeable, though, how much people really, there was a need to kind of adapt to what their professional style was. And so as a community engagement organization, we had to learn how to work with them that way. It was really interesting outcomes for us.
I love that term, tech positive. I'm going to start using it. I'm tech positive. Well, we have about 5 minutes, so I thought I would give each of you an opportunity to share what you think people should take away from our conversation, whether it's about your organization, whether it's about telemedicine, what you would like people to walk away. And we'll go in the same order so that Dr. Cameron gets the last word today, since he was the last to start. So Chelsea, would you begin?
Sure. I think, as I've said a couple times, we all have telehealth, especially in the space of a provider in an office, a patient in a home, is still very new. It's really been a year that we've all been doing this. So I think we still have so much to learn still on how do we optimize technology? How do we improve broadband access? How do we educate our providers? We're using the term website manner as a way of predicting how a provider will interact on a camera. And there are definitely, there's providers that they've practiced their whole careers, and it is tough. And so how do we educate them, or how do we utilize tech positive providers to use telehealth instead? So there's so much that we're going to learn. I think telehealth is going to advance a lot in several of those spaces. And I think there's a lot of other technologies we're going to add. I know clinical wearables came up once or twice that will also enhance that virtual visit, the ability to do a physical exam virtually, that will help enhance the experience. So I think this group, these types of groups will be defining the future. So I think it's a really exciting time to be in telehealth and digital health and healthcare. And I think, as I said, we're going to learn a lot and see a lot of changes over the short term.
I think I'm next.
Yeah, you're up next. Did find my unmute.
Go, my turn. Thank you. So yeah, thank you again, Jessica, and your team for allowing this to occur. I mean, I think it's a topic that needs to be discussed, and I think that is really the takeaway for me, is just continuing those conversations, continuing those discussions, really figuring out how we where we are with it right now, how we can continue to build on that. Whether it be in relation to the, policies and the regulations, or the platforms that we're using in order to deliver the services, the education surrounding, the clinicians that are providing the services or those that are receiving it, just really continuing that discussion, for all of those different, aspects of how this is being delivered, and the importance of why we need to really keep that, available to use, because, if we learned anything through last year is that we don't know what to expect, really. So if we, something else could happen, hopefully not, but something else could happen, in the next, 5 years. And if you have things put in place and you're prepared for it, then we're getting ahead of it, as opposed to just waiting for something to happen and then throwing something together, which, I think a lot of people threw things together that worked very well, which is great. But now we just need to continue to build from there. So thank you.
All right, I think I'm next. Yeah, and I think just to reiterate, it's just the same ideas as Chelsea and Scott, and like we've all talked about, is really about listening. And this is an exciting time. I mean, we are at a precipice. We are going. We've had a great period to test out telemedicine. I don't think we would have ever gotten to this point without a global pandemic. And as horrible as the pandemic has been, I try to think about that, like we at least have had an opportunity to try this out and figure out, what are we going to do moving forward, and what can we glean from the very best of what we did, and where do we want to see that moving forward. So I just appreciate so much physicians and providers who are willing to try, who are willing to adapt, who are willing to change. We at the department, we are open to any and all discussions. We're gaining information as quickly as we can. We're trying to ask as many questions and be involved in as many conversations as possible. And hopefully when we put out kind of our post-telemedicine or post-pandemic telemedicine policy, we'll be getting close to where we want that to be. We really hope that these conversations, they are informing this. Lots of people in our heads all the time as we think through this. No conversation goes unnoticed for us. We're really paying attention to it. So I just want to say again, thank you. Appreciate it all. Appreciate all of your feedback and thoughts. And we look forward to what this looks like and what it continues to evolve into.
And I'll bring up the rear. So thank you guys for doing this and for educating me about telemedicine. This is really helpful for me to learn from all of you. And I would just say a couple of things. First of all, if you are interacting with people over 60 or even really over 50, but we target 60 plus, who want technology engagements, technology support, people get free classes at seniorplanet.org every single day. And they're in English and Spanish, and they're on all sorts of different topics for beginners and for more advanced people. So I encourage people to take a peek at the website. It's just seniorplanet.org. It's available for everybody. All the OATS programs have always been free to the end users. And so that's a useful thing for people. Number two is help us solve the connectivity crisis. We have this initiative called Aging Connected, where we set up a website called agingconnected.org. The emergency broadband benefit is the first ever major subsidy for older adults and anybody who's lower income to get online. $50 a month subsidies from the federal government. It lasts until the end of the pandemic. So if you get on in May, it could be $600 for people. And it's a big benefit for first-time users, for others that are learning to use technology. So agingconnected.org will help you figure out where the status of all that is as this goes forward in the next couple of months. But we're also now part of AARP at OATS. We're an affiliate organization there. So if you connect to your local AARP state operation or the national, you'll connect with us there and be able to help advance that agenda around connectivity, which is really critical. Thank you guys really for having me on this. That was great today.
Well, I just really want to thank each of you for sharing your expertise and your insight. It's very much appreciated. I do realize that this is an evolving topic, so hopefully we'll convene again and discuss where we are in a few months, perhaps. Just for our audiences, so our audience knows, and so all of you know, we've recorded all of today's discussions, and we'll be putting them on our website. You can find those at connectednation.org/telehealth summit. Also, I'll include some of the resources that Dr. Camber and others have mentioned here on that webpage. If you had questions that we didn't get to, I know we didn't get to everything, and I'm sorry for that. But if there's something you think of at a later date, please feel free to send them to me at info@connectednation.org, and I'll track down the information you need. I have all of our panelists' phone numbers and emails, so I can get them for you. So again, thank you, everyone. We really appreciate your time today. Now I want to hand it off to Eric Frederick, who serves as the Vice President of Community Affairs for Connected Nation and is the Executive Director of Connected Nation Michigan. Eric, take us away.
All right, thanks, Jessica. And I know that we ended right at 3:30, which is unusual for a Zoom, so I won't make this long at all. Big thank you to all of our panelists today, all of our guests, all of our attendees with your questions. We really appreciate your thoughts and comments on this critically important topic. And like Jessica said, a copy of this webinar will be available on our website and across social media as well for those who weren't able to participate. Again, thank you to all of our panelists. Thank you to Lieutenant Governor Gilchrist for his opening remarks on this important topic. Thank you again. Please reach out if you have any questions, comments, concerns about this important topic, and we'll connect you to the right folks. So thank you, and I hope everyone has a great rest of their day and a great week.